The 90-90-90 target, that means by the year 2020, 90% of people with HIV should know they're infected. 90% of these who know their status should be on treatment. And 90% of people on treatment should have successfully suppressed the virus. That's the goal of the UN AIDS Fast Track Plan. Dr. Chirilu is the Associate Director for the HIV and AIDS Program at UNICEF, on Skype from New York. And I'm with Stephen Smith in the studio. He is the United States Health Attaché to South Africa, works closely with the US President's emergency plan for AIDS relief in the country. Good evening to both of you. Dr. Chirilu, how are you with this 90-90-90 plan? What's the point of it? Is it an admission of success or failure?
Well, it depends how you look at it. For UNICEF, our mandate really is focused on children and adolescents, but also the mothers. So when you look at where we are in terms of the progress we've made towards 90-90-90, which is really what is going to get us there in terms of controlling the epidemic, I can proudly say we've done very well when it comes to treatment access to pregnant women. And South Africa is one of the countries that really paving the way on this. Over 95% of women in South Africa have access to antiretroviral drugs to keep mothers healthy, but also to stop the transmission from being passed on to their children. And so we have reason to celebrate, because globally what we are seeing is that there's been marked decline in the number of new infections in children under the age of 14. But the same is not true when you look at those children that are still getting infected, and when you look at the adolescents that are infected either because their mother passed on infection to them or they get infected during adolescence itself. The progress around adolescence is not the same. We see across the board, across countries, that adolescents are worse off in terms of treatment access. And when you look at children, globally, we have about 52% of children under 14 accessing treatment. The question is, if 82% of mothers are accessing treatment, why are children lagging behind? And there are many, many reasons for this.
Yes, I mean, I was going to ask you, it seems that there's success in certain areas and then you have a real dramatic fallout. What do you put that down to?
Well, when you look at children, first of all, we need to identify the mothers that are infected, because the infection is passed on mother to child. And we're doing well in identifying infected moms and putting them onto treatment. But when mothers are coming back with their children to our services, somehow things fall through the cracks, and we're not testing babies to be able to identify whether they are free from infection or not. And part of the reason is that we have not simplified the testing technology for children. Samples still need to be sent out to centralized labs to actually diagnose a child with HIV. And that for us is not good enough, because HIV infection in children is very, very aggressive. 30% of children untreated will die by year 1, and 50% will die by year 2. So we have to really find those children very early in life and put them onto treatment. Okay. And South Africa has led some of the way in terms of defining how to make sure children have access to testing access.
Okay, so a bit of good news in a dismal scenario, Stephen Smith. I'm sure none of this is a surprise to you. Tell us a little bit more about the work, the US work here in Africa and South Africa, and what it is that you are seeing on this day.
So thank you for having me. So the PEPFAR program, the U.S. President's Emergency Plan for AIDS Relief, for 15 years has been committed to the fight against HIV globally. Here in South Africa, we've partnered with the South African government to help support just what you described, the largest HIV treatment program in the world. We are looking toward epidemic control. It's still a long way to go. So everyone recognizes the progress we've made. We have more than 4 million people who have access to life-saving treatment. That's a tremendous accomplishment. Yet we have gaps, and we have not just millions more who need to be put on treatment, but we have gaps like we were just talking about. The children do not have enough access. There are other populations, young women, who are at particular risk. So what we are doing here is working on one epidemic, but recognizing that it's actually multiple epidemics in multiple places, and we need to target each of those populations differently.
What do you mean by multiple epidemics?
The epidemic in young women is very different from the epidemic in young men. The epidemic in children is very different from the epidemic in adults. And so we've learned we have to actually look at this differently. And when we want to reach epidemic control, we have to look at each one of those populations and deal with their unique set of issues. So what PEPFAR is doing is working with the South African government, working with over 100 organizations here, working with people living with HIV groups, working with all the stakeholders who can contribute to really make a difference. And so where we've come is tremendous progress in 15 years. Where we have to go is still a long way to reach those 90-90-90s and epidemic control.
Because Dr. Lewa, South Africa has the highest, or, most of the population in the world is suffering from this epidemic. What sort of impact does that have on society, and how hard does it make your work if, as you're saying, Stephen, that there's no one solution for all cases?
Well, when I look at South Africa, despite the fact that we have the largest epidemic in that country, we also have learned a lot of the lessons we have from that country. Because what has happened over the years in South Africa is that we've had such good political leadership and government commitment, translating really into action on the ground. And the fact that we have in South Africa a lot of technical capacity and skills to actually be able to look into the program and start to ask the questions as to where do we need to focus, how do we build efficiencies in the program, and how do we make sure that as we program, we are actually focusing on those things that actually are likely to make the biggest difference. South Africa has paved the way on that. And so when I look at what we are starting to do in the rest of East and Southern Africa, there are lots of lessons to be learned from South Africa. As I sit here in New York, part of the work that I do is to look at what's going on in the different countries and to start to cluster countries by what we call epidemic typology. The countries that are similar, what is it that we can do to make sure there's that south-to-south learning? And I think for East and Southern Africa, the countries are very different in terms of vulnerability and why the epidemic is the way it is. And we need to do a better job to leverage the South African capacity to make sure that other countries in the region can benefit to get to the level that South Africa has reached in terms of implementation of some of these programs.
If it's as complicated, how do you get funding? What sort of challenge is there in getting money? And I know that so many people are suffering from donor fatigue because there are so many issues around the world.
Let me first say, here in South Africa, the commitment by the South African government is sustained, and they support more than 75% of the response. So we're very proud and pleased to partner with the South African government because of that commitment. But globally, this is still a priority, and there are 36 million people living with HIV, far too many new infections, far too many deaths. It's unfinished business. So the United States government is fully committed. We have committed through PEPFAR the largest commitment of any single country to any single disease. And we are there shoulder to shoulder with South Africa, with really dozens of countries and hundreds of organizations around the world to get to epidemic control.
Is this going to be safe under Donald Trump's administration?
We've had this program for 15 years. It was launched under the George Bush administration. Administration after administration continues to support this program. We have broad bipartisan support right now. So we have all the confidence, and we have unfinished business. So we are continuing our commitment. And here in South Africa, I will say we may have an announcement on Sunday. If you stay tuned, we have some very exciting news coming.
You don't want to break it here first? Come on.
I will break the news that we have something to announce.
Well, it's obviously good news because you are smiling. Dr. Chulo, when it comes to treatments, I mean, you say South Africa's ahead of the curve here, but there is no cure yet, is there? Do you think we'll see one soon? How far are we down the line there?
Well, I can say, yes, you're right, that we don't have a cure yet, but what I can also say is that we've really simplified treatment so that many people can access. Treatments are not just better in terms of containing the virus, but also they are safer in terms of toxicity and side effects. So when you look at the work we've done over time and the ability to which now countries can leverage resources to make these treatments affordable and accessible to people, I think.
Right. Well, we've lost her there for a minute. I should imagine the US's incentive, obviously you don't want anybody to suffer, but a stronger population, a healthier population makes a stronger economy, stronger for the continent. Sure.
I mean, PEPFAR is a program born out of the compassion and commitment of the U.S. people, the U.S. taxpayers. When PEPFAR was started, there were very few people accessing treatment in many countries, including in Africa. And in the United States, people had access, and it just wasn't right to not have that access provided to the rest of the world. And now we have access, but we have unfinished work. So yes, we would love to see more healthy populations, people living their full lives. If they get on treatment, yes, they're not cured, but they live their full life. There is no reason that they can't have every opportunity, have children, really do everything as if they were uninfected, but they have to stay on their treatment to keep their viral load down and protect the people.
That's very important, isn't it? I know that's a big problem. Do you think people really understand today what HIV/AIDS is all about and how to look after themselves and how to work on that stigma that I know is still there?
You know, we wish they did, and many people understand it very, very well. The people who don't are really usually the people at the highest risk. Sometimes it's young people, sometimes it's vulnerable populations. What we've seen in the latest survey from the HSRC right here in South Africa is that knowledge of HIV risk has actually gone down, and that is unfortunate. So we have now recognized that and have work to do to make sure that people understand the risk as well as all of the new tools we have, because we do have much better tools, as we were just hearing, better drugs. We have new interventions,
I mean, that's
circumcision,
flies in the face of everything that we're seeing, right?
We have a lot more work to do.
Yeah.
Well, we still have far too many infections, but I want to say we're very optimistic that we can reach epidemic control. We are going to, usually you reach epidemic control when you have a vaccine or a cure. In HIV, we're going to get there without those things because we have all of this commitment, all of these tools, and we're going to put people on treatment to reach epidemic control. That's the 90-90-90 in a nutshell.
And I look forward to hearing your news on Sunday.
Excellent.
Stephen Smith, thank you very much. Dr. Chulo, who we lost a little earlier on, thank you too. Thank you. Still ahead, key population groups that are particularly vulnerable to HIV and how South Africa can help them.